I keep hearing what we can't afford. We spent $3 trillion on a war that nobody should have stuck off. Okay? Don't tell me what we can afford. Americans can afford anything we want to buy. Because we're borrowing money to pay for that war. And nobody is getting health care out of it. Okay? So let's talk about not what we can afford. Let's talk about what we want to spend money for. And if we don't want to spend money for health care, what in the world do we want to spend money for?
Also, I'd like to add that when we're talking about the affordability of this bill, it reduces the long-term deficit by billions of dollars over the next 10 years. What we really can't afford is the inaction being proposed by the administration. I'd also like to say that Kyle took care of my rebuttal on the legislative process.
Okay, thank you. Burlsworth, y'all gonna make me understand?
Yes, thank you so much. All I wanted to say is what I based my information on, because I haven't time to look at the shell bill because it's not going to be totally that way when it's done anyway. I based it off HR 3200, which is the mother of all this. And I'm going to give you several breakdowns here, but on page 50, section 122, in the health care bill, it would be provided to all non-U.S. citizens, legal or otherwise. The government, on page 58, the government will have real-time access to individuals' finances, and a national ID health card will be issued. On page 59, lines 21 through 24, government will have direct access to your bank accounts for electronic fund transfer. Now, my whole thing is I had to look at the HR 3200 because I worked session, and I know they have shell bills, and then later on the legislators can come back in and implement what they want in these shell bills, and that's dangerous. So all I'm saying is this report needs to be looked at, the mother that started it all, right here, and broken down line for line, and if you like it, then embrace it and pay for it. If you don't, then I suggest you all get together and let's see what we can do about this, because it bothers me. It really bothers me. On page 22, it started off, it mandated the government will audit the books of all employers that self-insure. So that would be like an IRS audit. You know, so all I know is there's things that we need to be concerned about, and let's break it down line upon line, precept upon precept. Here a little, there a little.
Thank you, Dr. Nash.
I just had a question on which version that you were looking at, because I did not, I just read the detailed summary of the one that just came out of the House, and that is not.
Okay, that was the HR 3200 I just referred to it. That was the one that I was referring to here. The one that's just coming out of the Senate, we don't exactly know what's all going to be implemented.
I'll come back to you in just a second, the section I think you're referring to in section 152 follows section 143. It's in the middle of the section that limits this to all American coverage. And the part I think you're referring to might not be correct in the copy you have, because it's simply a non-discrimination clause in coverage, and in terms of health care, not coverage. And so the thrust of it is that there will not be discrimination relative to American health care, but it still doesn't change the fact that health care is limited to American citizens.
Okay, this came from the Dean of Liberty University School of Law, Matt State.
No, I pulled this off of the U.S. Senate website this morning to make certain I had your current information.
Okay.
And
well, anyway,
I just want to keep the facts clear. Cal.
Yeah, and the HR 3200, this is something that I think it was understand too, is that all three versions of the House, there are three different versions, three committees in the House that have jurisdiction to write health care reform. So all three of those bills were called HR 3200. The compromise, the bill that comes out of the House, will also be called HR 3200. So whenever you call HR 3200, there's four different ones.
I called it the mother.
Well, the combined version is the one that you keep worrying about, and that is HR 3200.
Okay, let's hold on for a second and get back on track. Cal, you need another 10 seconds.
I'm sure that there are people who would like for nothing to happen. in this process. We are closer in this country to getting health care insurance reform than has ever happened in the lifetime of any person sitting in this room. And so there are a whole lot of interests. The insurance industry is worried about this because there's going to be competition. There are those who are worried about it because if we make health care insurance more affordable, then more people will have access to it. And if more people have access to it, then things happen. If you have better health care, you can live longer. If you have better health care, you can learn better. If you have better health care, you can do more things. There are certain people who have better health care because they have more money, and they don't care if other people don't have better health care.
Okay, and y'all heard of Canada's social system? They're getting away from it. It's not working. They've got long delays, people getting service. Great Britain, think of Great Britain for a second of its overhead and its healthcare system. The largest employer in the world is Red Army. Second largest employer in the world is the India Railway System. Britain is not near as big as America in size. Britain's healthcare system is the third largest employer in the world. Now imagine the overhead it's going to take that bureaucracy. They want 51 new departments to be able to handle our healthcare system. Imagine if you think it's hard to get into the DMV to be able to get healthcare service, because you cannot compete in business against a government that doesn't have to be able to do anything. They can just wait. The other side of the fact is more access. Think about it. Why is something more expensive? It's because it's worth something that people don't have. There's more need for it. So if this water is plentiful, then you'd think the price would go down. But if we don't have as many doctors and there's more people that want access, the price goes up. The reality is, it all sounds good when we talk about it, but when we got to go walk it and live it, it could be a different story.
The House bill does include provisions for increasing the number of primary care providers to deal with the increased access. So it's not that these things aren't addressed. I would say let's pay attention to what is written down. It's a more comprehensive bill that includes many things beyond what we're discussing. And we already have waiting lines and things for healthcare services.
Okay.
And we have, and they have, Great Britain and Canada have higher health status than the U.S. as a whole. Also.
Yeah, let's hang on a second. I don't want to get involved down arguing about Great Britain and China and other places. Right now, I'm not aware that a great number of folks are coming across the border from Canada into America trying to relate to health coverage. Let's do this. I'm going to give you 30 seconds. I know Bob died and get back to this. He's spoken with opinion. He wants to get back on this, and then I'm going to Bob, with Meeks, Burlsworth, and Simon, and then over 30 seconds.
They say by the year 20-something, 2017, 2020 or something, we'll be over $400,000 short already. 2019. If we don't do anything, and if we do make this radical change without an analysis, without monitoring how we're going to make a change and see what the effect is, people in business will sit there and take a model and they'll say, well, if we did this, what would that do? Not wipe out the whole system and start over. It takes over 8 years to even start off from the beginning for one doctor. How many doctors are in the queue to start delivering for the massive number of access?